have a group from Italy, and I'm going to let you guys introduce yourselves and the topic, and we'll dive right in.
Okay. Can I share my screen?
We are ready to go.
Can you see my first slide?
Yes, we can.
So let's start. Good afternoon to everyone. I am Mario Robertis. I'm a neurosurgeon. I work in Milan in Humanitas Research Hospital. And today I'm going to present you my residency program thesis work. And I would like to thank Professor Gasbarrini and the whole equipe of Istituto Ortopedico Rizzoli of Bologna for the brilliant contribution and to let me carry out this work, in particular Dr. Cristiana Griffoni that is connected with us. So let's go with the presentation. I have no disclosures to declare. Let's start. Chordomas, as all we know, are low to intermediate grade malignant primary bone tumor. The common rising site is the axial skeleton, and the mobile spine is involved in lower percentages as opposed to sacrum and skull base, almost 20 to 27.5%. Surgery still represents the cornerstone in the treatment of this pathology, in particular in adherence to Anakin appropriateness criteria, so with the goal to achieve proper R0 margin with unblocked resection with wide or marginal dura margins. But on the other side, the technological advances in terms of high dose conformal charge particle therapy are deeply changing our perception of chordoma management for the virtuous impact, the potential virtuous impact on local control and overall survival. The primary point of this study is to analyze the impact of two different treatment strategies, in particular unblocked resection with proper R0 margin, and on the other side, hybrid therapy, so a deliberate Anakin inappropriate resection with adjuvant charge particle therapy on local control first, and then overall survival. In secondis, we analyzed the morbidity of the two different planned surgery, a planned unblocked surgery, and on the other side, the planned intralesional surgery with particular emphasis on the role of mechanical complications, incidence, or risk factors, considering also the morbidity, the adverse events, general adverse events, and the one related to the adjuvant therapy, the adjuvant adjuvant therapy. And at the end, we conducted an outcome analysis. This is a retrospective, as said before, observational monocentric study conducted in Istituto Ortopedico Rizzoli. We have to thank also CNAO in Pavia and the Proton Center of Trento for the adjuvant treatment. And inclusion criteria are patients with a lesion located throughout the mobile spine of at least 15 years old, with a minimum follow-up, minimum complete clinical radiological follow-up of 2 years. All surgical patients, both for virgin or recurrent chordomas, with just one only previous surgical treatment to reduce the confounding factor. We collected a conspicuous number of data from the demographic general data. In particular, symptoms were assessed in the same way at baseline, the last follow-up, assuming ECO5 devices from at baseline, the last follow-up for the comparison. Obviously, patient with previous intralesional surgeries, or for example, patients with previous open biopsies were considered not virgin for the capsule, for the margin violations of the tumor. In particular, attention on patients that received subtotal resection. In particular, in this subpopulation of the cohort, we conducted a volumetric assessment to judge to assess the potential impact of the extent of resection on the local control in the risk analysis. In particular, considering the percentage ratio of pre-hydrotherapy volume on the pre-operative volume at baseline, and focusing in the 50%, arbitrary in the 50%, a cutoff to assess the potential impact on local control itself. The final analysis, 33 patients entered the final analysis, in particular 22 males. The mean age absolutely in line with the epidemiologic data concerning the age, the classical incidence, age incidence of chordoma. Most of patients were neurologically intact at baseline. In the majority of cases, non-virgin with previous intralesional surgeries. 24 and 23 patients presented also invasion of the spinal canal, so the layered involvement according to the Weston-Biagini-Boriani classification. 14 patients were candidate to planned and block surgery, and 19 patients to planned intralesional surgery, but 2 patients at the postoperative pathologist assessment presented focal margin transgression, in particular with the macroscopic tumor residual postoperative pre-hydrotherapy imaging assessment. This 12 patients were enrolled definitely in the wide marginal margins group and 21 in the intralesional margin group. As we can see in the table, patient candidate to planned and block surgery were more likely to be profiled ASA less than 2, and the totality of patients with planned intralesional surgery, seeing the obliged adjuvant charge particle therapy, were candidate to a carbon fiber only hardware for the spinal stabilization. This is an example of our cohort, the most volumetric relevant of the cohort. We can see a proper R0 margin resection with prevertebral resection and the typical titanium reconstruction with the anterior column reconstruction with homoplastic graft, but characteristic is the reconstruction of the posterior element with the femoral roof adherent solidal to the rods with the just bend. This is just a topographic distribution details overview of our cohort. Just a few words about cervical spine lesion. All cervical spine lesion, because of the unacceptable neurovascular morbidity related to a proper unblocked surgery at this level, were candidate all to a deliberate and inappropriate surgery. So a planned intralesional surgery and all candidate to adjuvant therapy. As said before, 21 patients received postoperative adjuvant therapy in case of positive intralesional margin postoperative pathologist assessment, in particular carbon ion therapy in 7 cases and proton beam therapy in 14 cases, with a median time to adjuvant therapy, so time surgery to starting of adjuvant therapy of 12 weeks. This is an example of a proton beam planning, in particular conducted in the Proton Center of Trento. This is the classical CT-MRI fusion. In particular, this is one of the 2 patients of a planned and block with focal transgression of margin and a macroscopic tumor residual, with the typical chromatic dosimetric details of the different clinical target volumes considered, in particular the yellow one, the low-risk clinical target volume, the whole surgical bed, the green one, the intermediate risk clinical target volume that represent the preoperative tumor volume at baseline, and the magenta one, the boost, the high-risk CT2 boost on the tumor residual macroscopically seen in the MRI. This is, on the other side, an example of carbon ion plans with, again, with the different chromatic distribution of doses in a cervical lesion, and in this case, as typical in CNAO, they don't consider, as opposed to proton beam, the high-risk CTV and the low-risk CTV. 14 patients presented the first local recurrence after the primary treatment, with a median local recurrence free 36 months on a median follow-up of 45 months. And the risk analysis show that even without statistical significance, that the presence of pathologic fracture at baseline, the presence of tumor residual in the postoperative imaging assessment were both related to an increased risk of development of local recurrence. This is the same for carbon ion, but probably it depends from a bias related to the fact that patient in CNAO in particular, because CNAO have carbon ion and proton beam therapy, both availabilities. Carbon ion therapy is preferred in case of macroscopic tumor residual because the inherent characteristic of carbon ions is higher biological effectiveness, less hypoxia susceptibility, so better for selected clones or tumor with gross residual. The survival analysis showed no difference, no significant difference between the two groups, wide marginal margins group, intralesional margins groups in terms of local recurrence-free survival and overall survival. The same for the occurrence of a mechanical complication in the two different planned surgery group, the planned unblocked surgery group and the planned intralesional surgery group, considering that in our court, the majority of patients presented mechanical failures without loss of spinal alignment. The risk analysis for mechanical complication and at the time without statistical significance, probably for the restrict number of patients in the court, show that the sex males, the presence of pathologic fracture at baseline, a more aggressive approach, a combined surgical approach, even in presence of a circumferential bone graft and in presence of carbon fiber only hardware, all these factors were related to an increased trend to develop mechanical complications after the primary treatment, the index surgery. Postoperative adverse events were more likely to be detected in the planned intralesional surgery populations, and no significant difference as opposed were found in the intraoperative adverse event, general adverse events, but probably another time for a selection bias because we have to consider the type of the population at the baseline. Patient candidate to a deliberate intralesional surgery sometimes often are patient failure, not candidable to a more aggressive surgery, a proper unblocked surgery. So we can interpret in this way this finding. The morbidity, adjuvant therapy related, absolutely mild to moderate in line, acute and chronic after 3 months, absolutely in line with literature data about the toxicity of charged particle therapy. We conducted an outcome analysis, and in particular, we found a significant improvement in terms of mechanical axial plate control in both populations, with marginal margins and intralesional margins, but more significant in the proper R0 population, R0 margin population. An improvement in terms of quality of life represented by the EQ5 devices from was detected only in the wide marginal margin groups. We conducted also an outcome analysis with the same parameters for the two different charged particle modality, but no difference in the comparison inter-groups were found between the two populations, proton beam therapy and carbon ion therapy on the other side. At the last follow-up, more patients of the unblocked group, of the proper wide marginal margins group, resulted free from disease at the last follow-up itself, but with absolutely not negligible rates of local control in the hybrid therapy group, intralesional margins and adjuvant charged particle therapy, and the only two that registered in the intralesional margins group. In conclusion, we can say that unblocked surgery, unblocked resection is always to be preferred with a proper and early centralization of patients in referral center, especially in lesions intracompartmental with, for example, sector 4, sector 9, according to Western Viagini Boriani, free or in lesions without a significant involvement of the spinal canal. So in lesion without anatomofunctional constraint, also related to the clinical oncological general assessment of the patient himself. So preferring always unblock when possible. But on the other side, in light of the advances in terms of radiation delivery, optimization of technology, in particular in the high-dose conformal charged particle therapy, are changing this perception because Most of recent literature is talking about improvement in terms of local control and also in terms of overall survival. So every therapy, in particular in frail patient, in patient with huge high-grade huge lesion with high-grade spinal canal invasion, where the unblock surgery technique becomes harder, because more difficult because of manipulation of the specimen, risk of violation of the capsule itself, and risk of focal transgression of the margin. There are some issues that are still open because also ethical constraint prevents the center to provide perspective data, multicentric perspective data with rigorous methods, strict method, and we don't know if for example, a planned unblock surgery with a focal transgression is different in terms of local control from a deliberate piecemeal resection, even in case of gross total resection, when combined with an adjuvant charge particle therapy. So there are some issues still open, but I think that this positive impact of the hybrid therapy, the role of charge particle in a deliberate and inappropriate surgery, is absolutely not to be frustrated, but we have to study better this topic, because I think that in 20, 40 years, we will have interesting results beyond surgery aggressive as now. So thank you very much for your attention.
Thanks so much. Great presentation. A real pleasure to have you guys. My first question it has to do with kind of extrapolation of these data, because obviously you're talking about, we had learned that this was a third at the clivus, the mobile spine, and the sacrum, but I know you guys are saying about 2025. It's still basically a third. Can you extrapolate this information into clival or sacral chordomas? I would imagine sacral more than clival, because it's harder to get an en bloc in the clivus, or impossible. But with the sacrum, people do that. So what do you think?
I think that we have to consider that we are talking about same histotype, but different biological molecular entities. I think immediately to, for example, the OXA gene family, different expressions. If you know in literature, skull-based chordomas are described as completely biological entities, completely different pathological entity from sacrum, for example. In particular, the sacrum shows a significant more aggressiveness compared to the clivus itself. So as you said, in the clivus, an unblocked resection is obviously not achievable. So anything inappropriate, we can use the same name, is obviously an obliged choice. But for what concerns the sacrum, I think that the proper unblocked resection in sacrum is acceptable only in the lower sacrum, because nowadays huge chordomas, but only smaller lesions in S1, S2 are absolutely candidable to charge particle therapy as primary treatment. There is an interesting study of I think 2-3 years ago, of carbon ion therapy of sacral chordomas, treating in 2 arms, carbon ion therapy as primary treatment and unblocked resection. And also in that case, interesting result in favor to carbon ion therapy without entering in the lesion itself. So I think that the neurovascular, I think more neurological morbidity in case of upper sacrus is absolutely unacceptable. And I think the charge particle therapy is the choice nowadays. For skull base, I think that we are able in another way to promote a cheetoreductive surgery intralesionally, obviously, and then also in that case the adjuvant therapy is the solution. I can say also photon therapy, also gamma knife, also stereotactic radiosurgery and not only charge particle therapy. In this study, we assess the role of the charge particle because it's the first treatment proposed, but other groups are assessing also the role of photons, photon therapy, in particular the single fraction delivery, for the proposed probably more the more effective role on local control of the single fraction itself.
Thank you so much.
Yeah, fabulous work, and I too am impressed. I mean, such a vast experience that you've had with unblocked resections as well as subtotal intralesional resections with particle therapy. Some of the pictures that you showed, I believe, showed some instrumentation that looked like it might have been titanium based. And I wonder if you can comment a little bit upon the instrumentation that you use, especially as it relates to particle therapy, and whether or not you are thinking about some other materials that might be useful, such as a carbon fiber type instrumentation, and how that interplays, maybe for our audience, just how the interplace is with particle therapy and spinal implants. If you can comment a little bit upon that.
Okay, we're all talking about a monocentric series that start from 2013. So the surgical practice is changing also in Rizzoli itself, but it's important to consider also a non-negligible consideration, that is the cost of the instrumentation itself. So in a surgery that you can achieve a proper zero margin, you can use titanium hardware, and probably in case of local recurrence at distance, you can consider to reoperate the patient, changing the hardware in carbon fiber hardware if you cannot achieve another proper unblock resection, because in the majority of cases the revision surgery is absolutely intralesional in the majority of cases. So in that case, you have to reoperate the patient, you change your hardware in carbon fiber hardware, and you candidate the patient to the adjuvant therapy, charged particle, or particularly in the case of charged particle therapy, because the susceptibility to the artifact and the scattering is higher as compared to the photon therapy itself. So in that case, you can shift. Nowadays, in case in which at the beginning that you are going to perform a so-called planned intralesional surgery, when you can adopt the hardware, I think it's absolutely mandatory, because there are some important constraints for radiotherapies in deliver the particle therapy itself. So I think it's important to consider, but the finding in my study that the carbon fiber only hardware was related to an increased trend to develop mechanical complication after primary surgery is not in line with the recent literature concerning the use of carbon fiber hardware in oncologic surgery, spine surgery, because the instrumentation now and biomechanical studies are suggesting almost higher power of carbon fiber hardware in ossification, reduced risk of pseudoarthrosis, and low to failure compared to titanium hardware, as opposed to traditional literature that preferred titanium hardware, because seen stronger in terms of biomechanical terms compared to the carbon fiber hardware. But it has an important role in the bone hardware interface, inducing a more significant ossification after induction.
Yeah. I want to encourage quickly any viewers or listeners, they can chime in with questions. We still have the chat open for the next 5 minutes. Jason, you had another question?
Well, no, I agree, and I put in a little note. Please, this is a golden opportunity to ask key opinion leaders a question. But I underscore what you just said, I think it's so important to make a very personalized treatment plan for patients with these approaches. Not only are we thinking about en bloc resection or intralesional resection, but the type and even the biomaterials we're using. Obviously, the spinal instrumentation constructs, really just incredible experience that goes into this, and how difficult it can be for us to create a one-size-fits-all uniform care pathway or treatment algorithm for patients with spinal chordomas, since they can be quite different. You showed cervical cases and lumbar cases and sacral cases, and thinking about how one approaches those. But in terms of the experience that you've got on, which is already tremendous, what is it that you're putting in place to move the field forward in the years to come? Are you capturing a wide berths of information from Chordoma treating centers in Italy, or how is it that you see your ability to sort of advance this field of such a rare tumor etiology and to really power the next iteration of studies?
Well, you mean my perception of the changing in this in the treatment of this pathology in locally or in general worldwide?
Well, I think both. I mean, you're at a great center that has tremendous experience. Where do you take the next iteration of studies, both locally as well as regionally and internationally? Because this is not a study that can be done in a year at most sites, because of the rarity of these tumors and the long-standing nature by which you need to follow the patients.
Okay, personally, as I said before, I think that the role of this kind of radiotherapy, this kind of high technology, we can say radiotherapy, is changing this perception, because I think that in this is my personal comment, in 40-50 years we will able to perform always more or always less aggressive surgery, because the type of delivery, the modality of the delivery is changing. We can talk hours and hours about the contouring of the volume, about the methodologies of tissue sparing in the entry channel of the radiation in the surgical bed. Lots of consideration, and this has an important impact for the surgeon, because we are talking about surgical patients. We can think about cervical lesion. Years ago, probably in the referral centers worldwide, cervical lesion could be candidates to an en bloc surgery, even though the patient had a negative impact from a neurovascular point of view. This is absolutely unacceptable nowadays, with the improvement of the technologies in general, surgical technologies, min-invasive approaches, technologies from a radio-oncological radiotherapist point of view. So I think that we are moving toward the reduction of the indications of the proper en bloc. So I wrote in the last slide just intracompartmental lesions that are really prone to the proper en bloc surgery, because I have to promote absolutely in referral center an en bloc surgery if I can do the proper en bloc surgery, because we don't know nowadays if, as I said, a focal transgression in a planned en bloc surgery is similar to a deliberate total piecemeal resection. Even in case of gross total resection, we don't know, because both had positive margins at the pathologist assessment, but we don't know is in very different situations combining the adjuvant therapy, we can have an acceptable rate of local control. But we have to also consider that the local recurrence-free interval is different between the proper R0 populations and the R1, R2 populations. We have a trend toward a wider in time interval without local recurrence in the block. So that's why the majority of literature support unblock when possible. But on the other side, we have to focus very, very well this topic, because we have to ask ourselves when we can properly achieve this kind of surgery, in which anatomical segment, because mobile spine in particular is very complex, so have great variability in terms of anatomical site and inter-individual characteristics. So we have to make lots of consideration in an adequate preoperative planning. It's very important, and I think that the multidisciplinary discussion is really mandatory in this case, in this kind of tumors, more than in secondary tumors, more than in metastases. Absolutely. It's very important to plan the surgery and to share the surgical plan with the radiotherapist. It's very, very important.
Right. No, I agree 100%. I think your response was exceptionally thoughtful, and thank you so much, Randy.
Yeah, we're at the 30-minute mark, which is when we like to end it, keeping it short and sweet. Thank you so much for being a part of this. We look forward to more work coming out of your center on this. I'm staying tuned. I think the story evolves, and you guys did a great job, and it's a pleasure to have you on board. So thank you.
Thank you so much for joining. All right. Take care.
Take care, everyone. Have a great afternoon. Bye-bye.
You too.